Welcome to Neuro Stories, the podcast that highlights the people behind neuroscience at the Walton Centre. Together, we'll lift the lid on the complex worlds of neurology, neurosurgery, and everything in between, hearing fascinating tales of the incredible staff and services carried out in the hospital every day. Hello. You okay?
Yes, I'm fine. Hello, my name's Katie Gilkes. I'm a consultant neurosurgeon here at the Walton Centre.
Thank you for taking the time to have a chat with me today. Just tell me a little bit about what it was that got you into becoming a neurosurgeon.
At medical school, I really enjoyed all of the topics in medical school, but it was in our second year when we did neurosciences that I was like, this is just so cool. I definitely want to do something neuro. So it was very much neuro rather than surgery that was the attraction. And then as I started working, I really enjoyed specialties that had more sort of intervention associated with them, and realised that maybe neurology is very much a thinking specialty and didn't have so much interventional sort of aspects to it. And I was very attracted to doing surgery. I think partly at the time as a junior doctor, you worked ridiculously hard, and theatres is almost like a haven off the ward and into theatres. And also, I think when you're young, my feeling was my job needed to be really, really engrossing and all-encompassing. And so the two matched together, and I ended up doing neurosurgery.
Was there anything initially, before maybe even medical school, that made you think medicine is where I want to go?
I think at school, I was generally good at pretty much everything. I found, I was a good sort of all-rounder. I wasn't sort of genius at any particular subject, but I found that I really enjoyed the biological sciences, and medicine was an obvious thing to do. The continuous practical application of biological sciences, which is actually, it's quite hard to find a similar job in any other sort of scientific profession. And also, I think a big factor when I was younger was that if you go into medicine, you are guaranteed a job at the end. It might not necessarily be in the specialty that you want to do and the place you want to be, but you've got quite a guarantee of a job at the end, and that was quite important to me. The sort of environment that I'd grown up in, I'd watched my parents sort of struggle away trying to bring us all up, and actually that was quite an important factor in it as well. I'm not one of these people who wanted to be a brain surgeon when there was a kid at all. I'm quite surprised at the trajectory I've taken, really.
Really? So looking back, you're quite surprised?
It's really surprised me, actually, looking at the kid that I was, yeah.
What was that moment in the second year then in medical school when you were doing those neuroscience rotations?
I went to medical school at Cambridge where it was very scientific. I guess it was the physiology and the pharmacology and the anatomy of the brain that was just so fascinating compared to the other organs and systems that I'd come across. So I chose to do my third year doing neurophysiology, really sort of basic science, neuroscience, and that was almost like applying electrical engineering to biological systems, which was quite a challenge.
Where do your passions lie in that subject?
Increasingly within neurosurgery, people subspecialise, and I've seen that through my career. When I started out, consultants were much more general in their practice, and more people subspecialise. So I specialise in skull-based surgery, and that's purely what I do.
What does skull-based mean?
It refers to pathologies that are basically at the bottom of the skull. That's quite a challenge because at the bottom of the skull, be it at the front or the side or at the very base of the skull, is where all the nerves and the arteries in and out of the skull and sort of joining the brain. And so when you get lesions there, most commonly they're benign lesions. It can be a real challenge trying to work out how to best deal with them without causing damage to all those really important arteries and nerves and the brainstem, which is the most important bit of the brain that controls everything. It's quite a sort of niche specialty. Again, it wasn't a specialty I expected myself to find myself doing, but I really, really enjoy that particular aspect of neurosurgery.
I've had the privilege of being in theatre when you're doing your thing. It feels very high stakes. Obviously, I feel like brain surgery is high stakes anyway, but does it feel high stakes when you're doing it?
Definitely, definitely. I mean, and there are some cases which are obviously higher stakes than others. There is a really fine line between it being ridiculously successful and no problem, and things go not so well. And when things start to do not so well, it can go really, really badly. So, and it's trying to anticipate that beforehand, which is part of the key to skull base. I think it's the decision making and deciding with patients what the best thing to do is, and that's not always black and white, but it's really, really important. And I spend a lot of time establishing a really good relationship with the patients to help them decide what the best thing to do is.
And obviously with a complicated part of the brain, of the body like that, it's important for you to take them through every single option that they have. What does a day look like for you?
No day is the same, but within a week we have quite a sort of definite pattern. So we operate on specific days, and most weeks I operate at least once a week and sometimes twice a week. So they would be your theatre days. Skull-based surgery, some of the cases are very, very long, so you really prep yourself for that. You know, you're going on way into the night. And also I do a lot of joint operating with other specialties. So there's quite a lot of coordinating with colleagues, particularly from Aintree. So they work in a different trust, so we're trying to coordinate our diaries and arrange who's where and that sort of thing. But I regularly operate with my ENT colleagues on a Thursday. So we have theatre days, then I spend a lot of time in clinic, and I sort of split my clinics up into different clinics for different areas of skull base. So I'll do a clinic over at Aintree with the ENT surgeons to see the patients who ideally should be seen with them, or who need their hearing checked, or who maybe need scoping to see if their vocal cords are working okay. And I do clinics with the endocrinologists from Aintree when we see all the pituitary patients. There's a lot of joint working. And then we spend quite a lot of time doing multidisciplinary team meetings as well, where we discuss all the different cases and decide what we should do. You know, the radiologists check the imaging, check that we're on the right path, and everybody discusses the cases really to check we've considered all the options and that we're doing the right thing for the patients.
Sounds like a lot of teamwork. What is it like working as a team here at the Walton Centre?
When I first arrived, we had no specialist nurse support, and I've sort of established that service. And it's been, in many ways, actually not having it initially has been brilliant, because it's allowed me to create that excellent relationship with the nurses and establish what I think their roles should be in skull base. And I think it's really important because our patients have benign tumours and they basically are often with a service for their lifetime. And so providing that extra support is really important. And the nurses have started doing sort of special wellbeing events for the patients and trying to help the patients develop a little network themselves so they can support each other.
Why is that important? Devil's advocate, someone might say, well, you need to come in for theatre, you need to come in for a surgery, and that's it. That's all the hospital needs to do. Why go further than that?
Specifically from the perspective of skull base, often the patients, when they come in for theatre, they're very well. They have very little in the way of symptoms. And often, I routinely tell them they're not going to feel any better after their surgery. Most of them don't. And there is a risk that with taking their tumour out, they may develop new neurological problems, which are often transient, but it can be very difficult to cope with. For example, if patients have surgery for vestibular schwannoma, if you're taking the whole tumour out, you're dissecting off the facial nerve, and there's a very high risk that they may have some facial weakness afterwards, which will probably recover, but it's quite disfiguring. It'll make them feel quite embarrassed, it can make them quite difficult to eat. They might have other issues with mobilising, dizziness, and these are all things that just make it difficult to get on with life. And I think they find it very invaluable to have that specialist nurse support to say it's fine, get back into life. And the things, if they weren't there, then I would be getting the questions. So I can only give so much support.
You're only one person, aren't you? You know, I guess the alternative, if the tumour had been left there, is far worse.
These are the discussions we have in clinic. So if people have very, very big tumours that are causing compression of their brainstem, then it's very likely that it's going to cause a significant problem during the rest of their lifetime, and surgery is really the only option. And then there are other tumours where there are other options, for example, radiotherapy, and we talk about the pros and cons of the different options, and we come to a conclusion as to how we're going to proceed.
Katie, this is the quick fire round.
Okay.
Are you prepared?
As I ever will be.
What would you be if you weren't a neurosurgeon?
I think I'd have probably gone and been a GP in some remote Scottish island. They have to be pretty all-rounders, you have to be able to manage anything. But, if it wasn't surgery, I think about it, and I wasn't so worried as a kid about, sort of being able to make my own way, I'd have probably done something creative.
What's your biggest hobby?
So I do a lot of stuff outside of neurosurgery. Love being in the mountains. I do a lot of mountain biking, walking, do a bit of climbing, skiing. It's hard to choose between the two because I do a lot of music as well. Oh. I play in a local amateur orchestra.
What do you play?
I play the French horn.
Wow. What's your favourite song or piece of music then?
Oh, wow. So if it's a piece of music, it has to be Strauss's Alpine Symphony. which is basically a tone poem about ascending a mountain. Features loads of horns, so it's fantastic to play, and it also, I guess, evokes the whole experience of being in the mountains.
Do you have a favourite book?
I don't really have a favourite book that I go back and back to. The book that's had the most impact on me this year is one by Madeleine Tien. I don't know if I've pronounced it properly, called Don't Say We Have Nothing. And it's set during the Chinese Revolution and then up until Tiananmen Square. It's beautifully written and amazing into the whole sort of Chinese culture and development.
Favourite film? Do you have time to watch a film?
I went to the movies twice this weekend, but somebody gave me some cologne yesterday, so it's like the Godfather comes immediately to mind. What about Hidden Figures, the one about the Afro-Caribbean female mathematicians in NASA? I think I've got to say that's got to be up there.
I love that film. Food you love?
First thing that comes to mind is all the things I can't eat at the moment because I've been diagnosed with celiac, so I love cake and good bread.
No.
And those are the things that I really miss.
Food you hate?
Brussels sprouts.
Yeah.
Absolutely. Although they're better now because they've genetically modified them, so that horrible bitter taste that is what made me go as a kid is no longer an issue. They're not quite as bad as they were.
What's the best advice you've ever had?
When I was a junior doctor and I was about to start as a house officer, and I sat down with a flatmate and she said, always go and see the patient. And actually, you can never do wrong by actually setting eyes on a patient and seeing them for yourself and getting the stories directly from them. I think that's really good advice for any doctor.
Is there anything on your bucket list that you're hoping to get ticked off soon?
I don't know about soon. I'm working my way through the Scottish Munros. There's 282 of them, and I've got about 70 left.
Goodness.
So it's going to take me more than a year to do that, but I'm getting there.
Who's your hero?
That's a good. I mean, you have heroes for different things, and certainly within neurosurgery, there are particular people that I've had huge admiration for. But when I was a registrar, somebody mentioned about this lady who'd actually established the neurosurgical unit in Bristol where I trained. And I did a lot of research about her and wrote a paper about her. She was effectively the first female neurosurgeon in the UK and in the Western world. And at the time as a registrar, I just thought it was a good opportunity to get a paper, really. And I was sort of floating through, not having much of a problem. But I would say that as I have gone through my career, and certainly when I was involved in the unveiling of a blue plaque for her last year, I realised just how difficult it must have been for her to establish her career in an environment where the outcomes from neurosurgery were not good and there were no scans to show what you'd achieved or what you hadn't achieved. At least I have that now, whereas she didn't have that and was, I mean, her colleagues even managed to put her down in her obituary. So I was really pleased that I'd actually published that and stopped her from being brushed under the carpet. And my admiration for her, I think, has increased, with time as I've become more senior and realised how challenging it can be.
What's her name?
So she's called Diana Beck. And
then finally, something very few people know about you.
Oh, I appeared on an episode of Casualty when I was a registrar.
No.
They had a whole series involving quite a lot of neurosurgery, and on one episode they did a procedure called an external ventricular drain, which is a very common procedure in neurosurgery, and the neurosurgeon in the series was doing this, and so it's actually me doing drilling and opening of the skin on the fake head at the BBC, and we were using BBC porridge to try and make bone dust for the
So wait, it was your hands?
It was my hands, so they panned into my hands and then it panned out and she was doing this. So, and it was a very unlikely whole series of neurosurgical emergencies that I think basically took place in one episode. It was hilarious, but anyway, I was on it.
What motivates you?
I still do love clinical neurosurgery. I love that it's the patients, really. They're great. They just come in all shapes and sizes. And it's a real privilege, really, to treat people who are, often in a very vulnerable position. And I think when they get these sorts of diagnoses, it does reveal in many, many people an enormous resilience that they often never really realise they had. And so I think it's a real privilege to work with patients. and they show sort of some real bravery in that situation. There's an element of detective work with it. Just because somebody's got a massive tumour on their scan, it doesn't mean it's the cause of all their various problems. And quite often I do find myself diagnosing other medical issues that are actually more pressing than the tumour that's sticking there, that's been there for many years, for example. I do really enjoy the operating. It's a real challenge, but it's so satisfying when it goes well.
You're with people at quite an exceptional part of their life. How does that feel, being in that moment, being able to try to help, offer to help and investigate and find those things that are ailing them? How does that feel?
As I say, they find this resilience that they're able to cope with things that they never thought they could. I mean, we've had patients who've had, I remember there was one patient who had a needle phobia, and I was like, this is going to be a nightmare, doing some major surgery. Basically forced her to completely get through it, and then she came back with this tattoo with this brain on her arm to prove that we'd helped her get through her phobia.
What would you say is the most rewarding part? If you had to boil it down, what's the most rewarding bit?
I mean, the most rewarding bit is removing somebody's tumour, then making a complete recovery and having a really good scan, seeing them post-operatively and the whole thing coming together is, I would say, the most rewarding bit.
So generally then around neurosurgery, skull base, what is the picture like for neurosurgery?
When you're working, you think, oh, nothing's happened, nothing's changed. I would say certainly during my career when I was a registrar, the new thing was different radiation-based treatments. Yeah. So previously it was either surgery or nothing, and then radiotherapy techniques have developed, and now stereotactic radiosurgery and radiotherapy is very much part of the portfolio that we can offer to patients. I guess the recent thing that has affected certainly skull base in the UK is that now proton beam is available, and that's recommended for very, very specific skull base conditions, but it is available in this country now, so those patients that do need that can have that. But that also does have an effect on sort of some of the dynamics of how those particular specific conditions are managed, because of course there's areas of expertise in London and in Manchester. Neurosurgeons, and also particularly skull base surgeons, are never happy to sit still. They always want to find a new way of getting to somewhere and doing what we always did in a new way. So I would say that the other thing that has developed during my career is endoscopy. When I was learning how to do pituitaries, at first they were all done using a microscopic technique, and then endoscopic came in, and I was not actually trained to do endoscopy, but basically learned how to do endoscopy when I first started as a consultant.
What's the difference between that and endoscopy?
So an endoscope is basically like a telescope you put up the nose. So you put the telescope up the nose so that you can see where or wherever you're going. Actually, not necessarily the nose, but in pituitary we use it up the nose, and then you're also using instruments along the side. Whereas the microscope's more of a fixed thing. So with a microscope, we'd have almost like a speculum to dilate the nostrils, so you could see using the microscope down through the nose and into the pituitary. So you got a more limited view with a microscope. And then endoscopic surgery has developed hugely, and so now people are doing more and more extended approaches using the endoscope for more and more conditions. And then, having virtually exhausted where you can go up the nose and round the back of the nose, people are now going through the eye and doing transorbital endoscopic procedures. Goodness. So there's all these technical advances, and people develop their technique, and obviously very, very talented. When you go to conferences, you can come back full of enthusiasm, but you need to sort of temper that with how to develop those sorts of approaches and techniques in a sensible way that's safe. And you also do need support doing surgery through people's eyes. You need support from oculoplastics, for example, and eye surgeons. Those have been the big developments that I've seen in my career, really.
Where is it headed then? You mentioned obviously different ways of getting at the brain, like through the eye and through different practices. Where's the profession heading?
I mean, I don't think we're at the stage at the moment where there's some new treatment that's going to make us all redundant.
AI's not taking over.
Well, I think it may become very useful, particularly in skull base. We do a lot of follow-up imaging of patients and see if their tumour's grown. And I would think that there's a very obvious application for AI in that.
As a tool
for analysing scans, so the radiologists don't have to measure them all individually. There is a skull base surgeon from King's is currently doing a project on that with vestibular schwannomas, and we're all sort of taking part in this sort of Delphi consensus. And skull base is an obvious pathology for that, because you have got specific tumours that are in a specific place that are a particular size. I don't think we're quite at the stage where robots are going to be able to do what we do. But I think there probably are some aspects of our surgery that it could be very helpful and could speed things up, but we're not quite at the application stage of that.
Is there anything that stays with you over your career?
I can't think of any particular instances where I think, oh, that's when I became better at that or did this. But you don't realise that actually you are developing experience and you are becoming much more slick, or there are some situations you just know what to do, and that's sort of highlighted when you're training people, because what becomes intuitive because you've been doing it for quite a while. But I find it very hard to actually sort of identify particular moments when I saw the light, whatever, for this particular situation. Just
going back to what you said about that young person that you were, not having really any idea other than, certain areas where you were headed. What would you say to that person now?
I don't know, actually. I'm not sure I would give them any particular advice. My approach to life has always been, I've just taken every opportunity.
Just going for it.
Yeah, when it's risen its head. And it's not a very good, probably calculated approach to life at all. But I guess the thing that I have learned is I'm slightly obsessive, so I want to do everything absolutely very, very well. Even stacking the dishwasher, for example. so and if you've got that sort of personality, you cannot do everything. You can't absolutely do everything. And my approach has been to just do what comes up and to take the opportunities that arise, rather than being very calculated in I want to be doing this and this and this at this stage. That's been my approach. And I think even if I told my younger self, oh, if you want to have this, you need to be doing this, I'd have ignored them, and then I'd have been in a state of paranoia about it. So I probably just don't be so anxious.
Yeah.
Stop worrying. Don't worry.
Thanks for listening to Neuro Stories. You can listen to more episodes on Spotify and Apple Podcasts, and you can stay up to date with the latest news and events from the hospital on our social media channels, at the Walton Centre on Facebook and Instagram, and at Walton Centre on X. If you've got any feedback, email the communications team at wcft.communications@nhs.net. This podcast was recorded, edited and hosted by Sam Fleet from the Walton Centre's communications team.